Good morning on the West Coast. Actually, it's afternoon for me. Omid has asked me to talk about adjuvant and neoadjuvant dilemmas. I'm Jeff Weber. I'm a medical oncologist, and I'm the deputy director at the Laura and Isaac Perlmutter Cancer Center here in New York City. This is always a nice picture. It comes from an old article in the New England Journal, and I only show it briefly to show that we have two types of drugs that have really changed the face of melanoma treatment. And as you've probably heard, has really had an impact on cancer therapy in general. And these are so-called checkpoint inhibitors. These are antibodies that are human antibodies, so they look just like your own antibodies. And they block things. They do not directly kill tumors. They disinhibit the immune response. And I only show it to indicate on the left, CTLA-4 antibodies like Ipilimumab acts at what we call the priming phase, when the immune response against cancer is just getting going, and it mostly works in the lymph nodes. And then we have what are probably more important and more powerful antibodies called the PD-1 antibodies or PD-L1 antibodies, and they act at a different part of the immune response. It's called the effector phase, meaning the immune cells get into the tumor and then they're ready to do their thing. And let me tell you, the tumors are very clever. They have many ways of blocking the immune response. And the use of these antibodies is a way to disinhibit that immune response at the site of the tumor in what we call the tumor microenvironment. And as you'll see, they both work well when we give them as adjuvant and neoadjuvant therapy. Adjuvant, by the way, has many meanings in the English language. We use it in oncology to mean added to. So it's therapy added to surgery. And the first of these checkpoint inhibitor antibodies that came about was Ipilimumab, which blocks CTLA-4, and it had a fairly decent response rate in patients with metastatic disease. And in oncology, you know, we're not that original. If something works to shrink metastatic cancer, the next question is, would it work after surgery in those whose tumor is gone, at least to the naked eye or to the X-ray, to prevent recurrence, because a lot of those patients have a chance of recurrence. So this was a trial. And as you can see, these are patients who already had surgery, who had stage 3 melanoma. That means they had lymph nodal or locoregional spread of their tumor, but the surgeon was able to get rid of all of it by the naked eye, by exam, and by scans. But overall, about half of those patients eventually are going to relapse, which is not good because many of the relapsers will die. This was a randomized trial. And it was a blinded trial. It was double blinded. That means neither the oncologist treating the patient nor the patient knew which group they were in. And it was a straightforward design. A computer flip of the coin determined on a one-to-one basis, you either got Ipilimumab every 3 weeks, 4 times. That's what we call induction up there in that top brown box. And then after that, you can't just keep giving it every 3 weeks. If you did well at week 12 and had no recurrence or return of the melanoma, you got it every 12 weeks for up to 3 years. And up to 3 years, why 3 years? I think it was a bad idea, by the way. But nonetheless, the average patient cannot stand being on a trial for 3 years, I should add. The alternative arm, which that flip of the coin determined, was you got a placebo. And it's straight up placebo versus Ipilimumab. And the main thing you're looking for is either who relapses and who doesn't, and who survives and who doesn't. And I'll just say that the relapse rate was much lower in the Ipilimumab arm, but the most important information is on the next slide. It shows if you got Ipilimumab as adjuvant therapy after surgical removal of your stage 3 melanoma, you're in the blue curve of survival. And that means that the blue curve is looking a lot better than the red curve. The red curve is placebo, meaning no treatment. The blue curve is Ipilimumab. Now, 40% of the patients had serious side effects, which kind of tempered enthusiasm for this. And it was approved in the US by the FDA. It's never been approved in Canada, Australia, or anywhere else in Europe or anywhere else in the world, just the US. But look at the p-value for the difference in survival. It's 0.001. That means there's a 1 in 1,000 likelihood that this occurred by chance alone. That's pretty good. In our business, a p-value of 0.05 or less is good. 0.05, by the way, means there's a 1 in 20 chance that the difference you're seeing occurred by chance alone. You want to have a p-value that's like this, 0.001, that's 1 in 1,000. That's pretty good reassurance that this is the real McCoy, that this is true benefit for patients. So what does it mean? Of those who got up to 3 years of Ipilimumab after surgical removal of their lymph node melanoma, 65% were alive at 5 years compared to 54% who got nothing after surgery and just got a placebo. As I said, those who got the ipilimumab, the CTLA-4 blocking human antibody, had a pretty high rate of side effects, but they clearly lived longer than those who were just observed without treatment. So this led to its approval back in 2015. And now for the first time, we had a therapy that was an adjuvant therapy, meaning added to surgery, that actually was able to prolong survival in patients with melanoma. Then came along the PD-1 drugs. And now we're into 2015 or so. And by 2011, 2012, the PD-1 drugs were looking even better than ipilimumab. These are the PD-1 blocking antibodies. That was nivolumab and pembrolizumab. And this was a study, again, a straight up one-to-one randomization. And now you're getting nivolumab. In those days, it was given every 2 weeks, versus what was just approved, which was the ipilimumab. And again, similar regimen. It was what we call a high dose of 10 milligrams per kilogram intravenously every 3 weeks, 4 doses. That was the induction. Then after that, you got it every 12 weeks. But by now we realize that nobody in their right mind wants to come be on a trial for 3 years. So we cut it at 1 year on the hypothesis, the idea that if you can't boost immunity by the end of a year of treatment, it ain't happening. So I think that almost any scientist would agree that a year's worth of therapy should be enough based on everything we know. So this was 1 year of therapy, as you see in that blue box on the right, maximum duration 1 year. You either got nivolumab for a year or you got ipilimumab for a year. And the main endpoint, or the thing we were looking at, was who relapsed and who didn't. That's called relapse or recurrence-free survival. And here's the bottom line. This was just presented and published a couple of months ago. And again, I would much rather be on the green curve of relapse than the gray curve. The green curve is nivolumab, the PD-1 antibody. The gray curve is the ipilimumab. At 4 years of follow-up, which is a good number, 52% had not relapsed versus 41%. And look at the p-value, 0.0003. That means 3 chances in 10,000 that this was just occurring by chance alone. That's pretty good. That means you can feel very confident that this is the real McCoy and that there was a true benefit to these patients who had a reduced risk of relapse. And that's called the hazard ratio. HR, see that number on the second line in the box? HR means the hazard ratio. That's the ratio of what would happen if you got the real McCoy versus if you didn't get it. What is the reduction in risk? Meaning so it's 1 minus the hazard ratio is the percent reduction in risk. You have a 39% reduction in the risk of relapse compared to ipilimumab. If you do a back of the napkin calculation and compare it to doing nothing, it's 0.5. What does a hazard ratio of 0.5 means? It means you've dropped your risk of this thing coming back by half. And in any business I know, that's a pretty good number. You can also look by the stage. Remember, in this trial, we treated only the worst outcome patients. We did not treat stage 3A patients who had a very good outcome. On the left is the relapse for stage 3B, 3C. And on the right, we treated patients who had metastatic distant melanoma who had a single metastasis or 1 or 2 that were surgically removed to render them free of disease. Now, frankly, that's not so common, but as you can see, there were many more patients in the left than in the right group. But either way, the green curve looks a heck of a lot better than the gray curve, and there's clearly benefit. And the hazard ratio, the reduction in the risk of this thing coming back, wasn't all that much different in either group. And again, if you do the back of the napkin calculations, it looks pretty darn good compared to doing nothing at all. So no matter what your stage, you got benefit from getting adjuvant nivolumab. Now, the weird thing is if you look at the survival, there wasn't a difference. And think about that. Why is that the case? Remember I showed you the ipilimumab curve of survival versus doing nothing, it was clearly beneficial. But now we're not doing nothing. We're giving nivolumab, and if you failed, you could get ipilimumab in every country where this trial was done. Or if you got ipilimumab and you failed, you progressed, you could get nivolumab because it was approved. What is that called? That's called a crossover. And in a crossover design, it's almost impossible to show a survival benefit. Again, if you do the back of the napkin calculation and compare this result to what you would get on that old trial with ipilimumab, adjusting for the modern era, there's still a very significant benefit in survival of getting either ipilimumab or nivolumab, and the nivolumab benefit is better. What does it mean? It means of those who got up to 1 year of nivolumab after surgical removal of their lymph node or distantly spread melanoma, meaning stage 4 melanoma, 52% were alive and had not had return of their tumor at 4 years, compared to only 41% of those who got ipilimumab after surgery. Those who had more advanced disease with a higher, we call it the stage, were also better off with nivolumab compared to ipilimumab and clearly compared to doing nothing. However, whether you got nivolumab or ipilimumab first after surgery, as long as you could get the alternative drug and have what we call the crossover, your survival was the same. Now, there's another PD-1 drug that then came along. What I just showed you was a trial that ended in 2015, 2016. A year later, another trial was started with a similar drug, and this time it's not nivolumab, it's pembrolizumab. They're very similar. They're almost identical. Think of them as identical cousins, not identical twins, but identical cousins. They're not twins because they don't come from the same company. But these are very similar drugs. And this was a trial that was, again, a randomized 1-to-1 trial where with a computer flip of the coin, in a total of over 1,000 patients, you either got the pembrolizumab or this time placebo. The prior trial did not include placebo. It was nivolumab versus the active group of ipilimumab. Now it's pembro versus nothing. And you could cross over, if you look at the yellow box, that yellow box was put there by the guy who was in charge of the trial, who's an old buddy of mine named Lex Egerman. If you recurred while you were on the placebo arm, you could cross over and get the pembrolizumab. The idea being this was a test of whether getting pembrolizumab sooner or later was equally good or whether one was better than the other. Well, so far, no big surprise, getting pembrolizumab beats the heck out of getting placebo. Here's the relapse-free survival with less follow-up than with the prior trial. Here they're out to 42 instead of 48 months, but it looks pretty darn good. 59% relapse-free survival versus 41%. And if you look at that 41%, again, that's what you would see with a placebo in the modern era in terms of relapse. And if you look at that number of 59%, at less follow-up, if you expand it out to 4 years, it looks pretty close to what you get with nivolumab. So the two drugs that are cousins look pretty darn similar. And if you look at the hazard ratio, that is the reduction in risk, it's 0.59, it's almost half. So again, 41% reduction in the chance of you recurring if you get pembro versus just placebo. And if you look at the different stage, works in all stages. But are the stage 3A patients going to do better than the 3Bs and the 3Cs? Sure they will. Look at the result on the blue line. It's 80% in the 3As, 68% in the 3Bs, and 55% in the 3Cs. Is that a surprise? No, the outcome is always worse with a higher stage. You have more burden of tumor, bigger risk of relapse. But the bottom line is it's better than placebo in all of those groups. And if you look at something called distant metastasis-free survival, or where the tumor returns, it's very interesting. Look at the blue, you had a lower risk of a distant metastasis in blue over time than you did in red with just getting a placebo. And that's a hazard ratio of almost 0.5. That means it's a 50% reduction. So what does this all mean? Of those who got up to 1 year of pembrolizumab, the other PD-1 antibody, after surgical removal of their lymph nodal melanoma, 59% were alive and had not had return of their tumor at 3.5 years. Now, we're not at 4 years, which is what the nivolumab trial was, but it's pretty close. 3.5 years is a pretty good number. This is compared to only 41% of those who got observed after surgery. So obvious benefit in terms of return of the tumor. And those with more advanced disease with a higher stage were also better off with pembrolizumab than just observation. However, if you got observed, your chance of the tumor returning with a distant metastasis was higher than if you got pembrolizumab. And we don't want to have any distant metastases. That's bad news. Now, that's not all the good news, because those were 3 immune drugs. We also have targeted drugs, as Dr. Ferry showed you on that little timeline at the end of his talk. These are pills. All the other stuff I showed you was intravenous drugs that are immune stimulants that work indirectly. These are targeted drugs that target the molecules that drive the growth of melanoma. And they are mutated, at least The BRAF molecule, BRAF, in about 45% of melanomas acts as a driver. When we say driver, we mean like driving a car. It drives the growth and spread of the melanoma. And if you block it with a targeted drug, and in our case, 2 targeted drugs, it works pretty well in metastatic disease. So being simple-minded, the oncologist says, oh, well, gee, it works in metastatic disease. Does it work to prevent relapse after surgery? So this was the so-called COMBI-AD study. All of these studies started at about the same time, and they matured at about the same time in 2017. And again, this was 2 oral drugs, dabrafenib and trametinib, versus placebo, again, in about 950 patients. And about 900 patients. And the thing being measured was the time to return of the tumor, the relapse-free survival, and the distant metastasis-free survival. How long do you avoid this distant spread? Because distant spread is a surrogate. What's a surrogate? A surrogate is a substitute. It's a substitute for measuring survival. So if you measure the time to return of a metastasis, if it's metastasizing, that's bad news in melanoma. But here's the relapse-free survival, and now this trial has the longest follow-up. It's 5 years. Look familiar, that number, 52% at 5 years relapse-free survival if you get the 2 drugs, 36% if you get just a placebo. And that's a pretty big difference. Look at that hazard ratio. Now it's at 0.51 to be exact. That's a 50% reduction in the risk of this thing coming back with those 2 drugs. And look at it, looks like there's a plateau on the relapse-free survival curve as you go with time. And that's pretty impressive. That means about half those patients are probably cured. And that's very impressive to me. And it beats the heck out of, I'd rather be on that dark green curve than on that gray curve anytime. And if you look at the time to return of a distant metastasis, which usually is not a good thing, it's quite poor in terms of outcome, clear benefit for the pills in the blue versus just being observed with a placebo in gray, 65% versus 54%. Look at that hazard ratio. Again, it's close to 0.5. So that looks pretty darn good. What does it mean? It means of those patients whose tumors had a BRAF mutation, and remember, the mutation is not in the patient, the mutation is in the tumor. It's the genetic change. And if they got up to 1 year of the targeted oral drugs, dabrafenib and trametinib, after surgical removal of their lymph node melanoma, 52% were alive and had not had return of their tumor at 5 years, compared to only 36% of those who got observed after surgery. Those with more advanced disease with a higher stage, as we call it, were also better off with pembrolizumab than with just observation. If you got observed, your chance of the tumor returning with a distant metastasis, which is usually bad news, was higher at 46% than if you got pembrolizumab, in which case it was only 35%. So let's talk about neoadjuvant therapy. If adjuvant means therapy added after surgery, then neoadjuvant means therapy given prior to surgery, usually to shrink a tumor that maybe the surgeon can take out, but it's kind of borderline, and then make surgery easier for the surgeon. It only works if the response rate to the therapy in metastatic disease is fairly high. And fairly high means you figure at least 20–30% response rate, then maybe the treatment would be useful as neoadjuvant therapy. And there's been a lot of hoopla about this, not a lot of data. But recently, there's been a fair bit of data, and let's just quickly go through the small number of trials that have been done. And why does anybody care about neoadjuvant therapy? Well, in the initial studies, it seems like giving this immune therapy, for example, prior to surgery induces a stronger T-cell response than getting an immune response after adjuvant therapy, which means the tumor's gone, the surgeon's taken it out. Having what we call a pathologic complete response, meaning if you take out the tumor and it's dead, there's no live tumor there, may be a substitute, surrogate, marker for true clinical benefit, meaning if you achieve a pathologic complete response at the time of surgery after you get your neoadjuvant therapy, well, maybe you won't need any further treatment. You could save a lot of time and morbidity and money. Pathologic response could be used to decide if additional adjuvant therapy is needed. And the other nice thing is, obviously, if you're doing surgery, everybody has tissue after the neoadjuvant therapy, so you can do all kinds of analyses looking for biomarkers. And again, this was probably the best trial. It was presented this past year at ASCO. And recently in a journal called Nature Medicine, there was some updated information. But if you look at the 3 arms, they gave 2 cycles of treatment. Normally, when we give treatment for metastatic disease, we give 4 induction cycles. These investigators said, hey, we can't afford to have the toxicity and the long time of giving 4 cycles. That would delay surgery by 3 months, and that's not acceptable to patients. I wouldn't want to do it. So they gave 2 cycles over 6 weeks, which is probably as long as you can delay surgery. And guess what? If you had a high dose of ipilimumab, your toxicity was very high, 40 or 50% in the blue arrow and the purple arrow. But if you flip the doses and gave only 1 milligram per kilogram of ipilimumab and 3 of nivolumab, it's only 20%. And the pathologic response rate giving the low dose of the ipilimumab was about the same as the high dose, even though the toxicities were higher. So guess what? Everybody decided we're giving 2 cycles of flip dose ipilimumab and nivolumab. And look what happened on the left. If you look at the patients who had either a complete disappearance of their tumor at the time of surgery, meaning you couldn't find any melanoma, or 90% disappearance, they did pretty darn well. At 2 years, relapse-free survival is 83%. That's pretty impressive. That's better than anything we've seen with any adjuvant study. And if you look over time at those who had a pathologic complete response in green, essentially almost nobody relapsed. It's just unbelievable. And actually, that number there represents 1 patient, I believe, who actually died of other causes, and that's scored as a relapse. So again, very impressive data suggesting if you give 2 cycles of combination immunotherapy prior to surgery, and you're one of the 60% of patients whose tumor disappears or almost disappears, maybe you won't need any further therapy. Because if you look at that green curve, 96.9% relapse-free survival at 24 months, that's pretty darn good. I can't complain about that. So this is interesting, and it requires a randomized study of giving neoadjuvant therapy and then doing nothing further if the tumor disappears, versus not doing neoadjuvant therapy, but just giving adjuvant therapy. What if neoadjuvant therapy isn't as good? We don't know. All the studies are small. And at the end of the day, in our business, truth lies in a randomized study. So what does this mean? 2 cycles of combination ipilimumab and nivolumab were given to patients with stage 3 lymph node melanoma that had grown to the point where you could feel it, or the word is palpate. 40% of those patients had complete disappearance of the tumor when the lymph nodes were surgically removed, and another 20% had 90% disappearance of the tumor. If there was 90% or more disappearance of the tumor at surgery, almost none of those patients had a return of their melanoma in 2 years. I showed you the relapse-free survival at 2 years was 97%. And of the 3%, that was 1 or maybe 2 patients who died of other causes. Those patients may require no further adjuvant therapy, which means you're going to save a hell of a lot of money and time and morbidity if you do the surgery and then you have no evidence of tumor or minimal evidence of tumor in those lymph nodes. So what are the conclusions of all this? Adjuvant PD-1 blockade with nivolumab or pembrolizumab has significant benefit in prolonging the time of the tumor to return, what we call relapse-free survival, in high-risk surgically removed melanoma. Overall survival is not different between the nivolumab and the ipilimumab arms of that trial called Checkmate 238, due to the fact that there was an inherent crossover, in my view. Adjuvant targeted therapy with dabrafenib and trametinib has equal prolongation of time to return at 4 years compared to PD-1 blockade. So amazingly, they all look very similar. Nivo, Pembro, Dab-Trem, very nice data. The ongoing trials are evaluating PD-1 blockade in a lower stage, stage 2B, 2C melanoma, with a lower risk of relapse than those with stage 3, but still a significant risk of return at 5 years. Neoadjuvant therapy looks very promising, but it can be a bit toxic, and it has to be shown to be better than adjuvant therapy in a randomized trial, or you have to be shown to be able to have it look equally good, but you use less drug. And for the same benefit, obviously, society would save money. Instead of a year of nivolumab, you give 2 cycles of ipi-nivo, might be half the price. So that's where we are, and we're making a lot of progress, and I think patients are clearly benefiting.